give an introduction to our speaker today. And we're extremely excited to have Mr. Hadlock with us. He came and spoke to my 285 class a little while ago, and I got from his secretary a little bio that is quite comprehensive and fairly brief, and so forgive me if I read a little bit more of that. So, Mr. Hadlock's bio has had a long career as a business owner and manager. He attended Ricks College in Utah State, where he studied pharmacy. After college, he realized that standing behind a counter all day was not conducive to his personality and left medicine to pursue private ventures in development. For 15 years, Brian owned and operated a large development company building jails, hospitals, church buildings, and shopping centers throughout the Northwest. After selling his company in 2005, he joined a community health center board of directors and advocates for providing access of good quality health care. In 2008, Brian returned to school in order to get a degree in a position that would help him for critical opportunities in state and national levels in changing healthcare. He attended BYU, Idaho, and earned a bachelor's degree in business and health theories. And he actually finished that degree in 2 years with a 4.0, which is good. That's something
Not recommended.
Brian was asked to take over the local community health center in 2011 in an attempt to bring it out of bankruptcy. He developed a new model of care and business model for community health centers that has received national attention from Northwestern Regional Primary Care Association, Idaho Primary Care, and Health Resources Services Administration of the United States. He serves as board member to Idaho PCA and the NWR PCA. He is also a member of the Community Health Center Network of Idaho. Although Brian spends the majority of his time operating a health center, he works with state and federal organizations to increase access to his He does all this to increase access to care. His first passion is finding ways for people with multiple sclerosis to live happy, normal lives and overcome the effects of the disease, which he himself has suffered with since 1999. So without further ado, Mr. Hadlock.
Thank you very much.
Let's give him a hand.
Supper, huh? Wow. So, I want to know where everybody's from. Who's from the East Coast area? All right. How about Midwest? Got somewhere in the Midwest? Where at?
Texas, like Southwest.
Yeah. How about in the South? How about actually in the South?
Texas.
Texas.
Florida.
Florida. Fantastic. Western United States, West Coast, everybody else? Everybody from out of the country? All right. Well, that's okay. I'm Brian Hadlock. I run a local community health center here in the area. And we have a service area that takes in 5 counties here in the state of Idaho. Now, has anybody ever heard of community health centers? All right, so who's heard of public health centers? So every state has public health centers. They're generally run locally. They're a lot of free access to immunizations, women's health, things like that. The problem is that public health has a very, very limited budget. And they can't offer a lot, especially in rural areas where we live in one of those, and it's just a huge, massive area. To give you an idea, our service area goes all the way to the Montana border, all the way to the Wyoming border, all the way over to Sun Valley, and then Rexburg is sort of the southern tip of that service area. So we serve about 76,000 people with our facility, and we have medical and dental, and it's full service medical and dental. So in our medical facility, we do women's health, child care, family medicine. We call it diapers to diapers, is what we do. And quite honestly, that is what primary care is. Most primary care facilities that have some type of an OB program essentially are set up to be able to deliver babies and to be able to care for that baby all the way to death. When you think of primary care, what do you think of? What's the first thing that pops in your mind when you think of primary care?
Family physician.
Okay, family physician.
Small clinic.
A little bit smaller.
Small incisions, or I mean small stitches.
Yeah, so some simple procedures. And that's pretty much true, but not necessarily on the small end anymore. Primary care, I like to, I guess, relate with prevention. Primary care facilities' main goal is to prevent you from either getting worse or from getting the disease at all. And that's really what primary care is. And so that's what we do on the medical and dental end. Now, we belong to a community health network. What that means is that we're a private, nonprofit organization. And there's about 8,000 facilities throughout the United States just like us. So essentially what happens is the federal government says, well, we have Health and Human Services here, and we want to be able to promote preventative care throughout the United States and in small rural communities where access is the barrier. It's either large rural areas, it could be in urban settings where there's just not enough doctors to take care of the population. So they address multiple issues. So what happened is that back in the 50s, they developed this program called community health. And they started in the middle of a farm field where they were working with migrant workers to provide them with access to health care. And since then, it's just kind of ballooned into this massive network of community health centers. Now, we're all locally run, so we have our own board of directors, and we are individual from all other facilities, but we are still part of this big network. And so we all work together to promote access to health care within our state and nationally. And I spent a lot of time doing that. So when you think of being an administrator over a health center or a hospital or a public health office, what are some of the things that come into mind about what you would be doing? Have you thought about that?
Billing insurances. Well, probably more so.
Okay. So the financial aspect.
Yeah.
So you have to oversee the financial aspect in administration. Now, there are so many layers of financial aspects in a facility. There's the billing part. There's the CFO that does payroll. She does the finances for the month. She does reporting. And community health centers do a lot of reporting. We actually receive grants from the federal government. And those grants help offset the cost to treat people for health care.
Do you guys have to apply for those grants every year?
We do.
Or do they just allow them to?
That's a really good question. So what happens is we have been deemed as a community health center, a federally qualified health center is what it's called. And so we essentially are on the roster to be able to receive a continuing grant. So every 3 years we have to rewrite that grant as if we're doing it all over again. We have to prove our need, we have to prove the need of the community, we have to put budgets together to project out 3 years. The other years we're just kind of doing a report card. But essentially we receive about 30% of our budget yearly from a grant. The main reason for that is that it allows us to charge people based on a sliding fee scale. Everybody ever heard of a sliding fee scale? It's a chart essentially that based on your income and your family size will determine what you pay. So for instance, does anybody know what it costs somebody without insurance to actually go see a doctor for just a regular visit? You're just going in because you think you may have pneumonia and he just does an exam. What do you think that costs if you don't have insurance? It's pretty close to $200. And we charge 30. How about a dental crown or a root canal? Any ideas?
800.
How much?
$1,000.
About $1,000. We're about $325. So that gives you the idea. Now, it's not just to benefit people without insurance, because most insurances, even if they have a dental plan, max out at about $1,000 a year. That's about all they're going to pay for you to go to a dentist and be able to have any work. So in that situation, even though you have insurance that covered it, what are you going to do after that? So our facilities kind of break down those barriers. I mean, that's our real reason, is to allow more people to access better quality health care. And the same is true in medical. So in our facility, even if you have insurance, you're still going to owe something. That's just the way insurance works. What you would pay is based on a sliding fee. So we have these facilities all over the United States. And they've been running for 50-some years. What we're seeing in healthcare is a huge shift. And if you remember, I talked a little bit about this about a year and a half ago, about how medicine's changing. The way that it's delivered is changing, the way that it's overseen is changing. And one of the biggest changes that we have seen, and it directly affects any administrator in a facility. The biggest change, quite honestly, is how you're paid. Because it's completely different, and it will completely change everything in this country. We live in a very conservative state here in Idaho. And the state has done everything that they can to oppose changing anything about the way that we do healthcare, up until about 2 weeks ago. The Republican Party has come out and says we're not fighting Obamacare anymore. It's a losing battle. It's not going to happen. There's nothing we can do about it other than go in and find ways to make it better. So the governor of Idaho came out and says, well, it looks like we're going to expand Medicaid in our state, and we're going to be doing it next year. So those are the biggest changes. What that means is that you have private insurance now for people who are getting it either through work or paying out of pocket for a private insurance policy. Then you have insurance exchanges. Now that is the insurance that people get that they have to qualify for. So depending on how much you make will depend on how much you pay and how much is subsidized by the state and the federal government for your insurance policy. The policies work the same, but how you pay for them is the difference in an insurance exchange. And then you have people that do not qualify for an insurance exchange. Do you know why?
We're talking about it in classes like the donut hole, or is that?
Not necessarily. So that's in Medicaid. That's Medicare.
Okay.
And that deals with prescriptions, and we'll pay so much, then you have to pay some, and then we pick up after you've paid up to a certain amount. That's the donut hole for the Medicare program. The health. Go ahead.
It sounds like they make too much to go on Medicaid, but they don't make it enough to, like, they're kind of in between.
Yeah, it's exactly what it is. So this whole Affordable Care Act came out and says we want more people to have insurance, and we're going to facilitate this by picking up part of what it costs a family to have insurance. Now, I'm not opposed to that. It allows more people to have coverage to be able to go in and see the doctor. The problem is that if you don't make enough money, you can't even get that policy, because they will only pay so much, and if you're deemed unable to pay your part, you're not going to qualify to even get that. So we have a massive population in the country right now that has no insurance, even with the Affordable Care Act. They can't access it because they don't make enough to even get the subsidized policy. So the idea is that Medicaid expansion would be the answer. So everybody else would go on Medicaid. It is changing everything about my job. And the reason is because when you talk about a Medicaid program, or you talk about insurance exchange programs, you're talking about reimbursements that are generally going to be lower than what we've ever seen before. Private insurance really doesn't have that big of a problem paying a decent reimbursement to a facility like ours, because they know what it costs to run it. But when you're getting into the subsidized programs and they give lower reimbursements, doctors are opting out of taking that insurance. So we have a huge population coming into the marketplace that we have to figure out how we're going to manage receiving less money to do the same thing. It's one of the biggest challenges in healthcare right now. And it's not going to get any easier. It's going to just become more complicated. I think that the way that they're going to handle it is that they're going to require facilities to meet certain standards, and then they will up your reimbursement. One of those standards is called PCMH, Patient-Centered Medical Homes. We are the only one in Southeast Idaho. We are a patient-centered medical home. And it took us 2 years to get there. And it's a new model. Well, the idea of patient-centered medical homes is not necessarily the new model. How we do it is totally new. Ours is attached with accountability for the patient and the provider. One of the biggest challenges that doctors have, and that as an administrator you have to find solutions for, is non-compliant patients. Anybody know what a non-compliant patient is?
Patients that don't do what they're told.
Yeah, and that is the #1 challenge for doctors. Somebody wants to come in and get help, but they won't do what the doctor tells them they need to do. Have you ever been one of those patients?
Take your medication.
Take your medication. Oh, I feel better. I don't need to finish the 10-day regimen. I only need it for 7 days. Oh, I don't need immunizations. I've heard all kinds of crazy stuff about them. I don't want to be immunized. It's a huge challenge in administration because you have to try and figure out how to keep your doctors happy and the patients happy, but one of them not doing their job. And with a patient-centered medical home, it kind of forces the patient to do their job, or they can't be seen the next time they want to come in. And it really is about an accountable care organization that has the ability to motivate patients to do what they need to do without hitting them over the head. And we've been able to do a lot of that. It's team-based, and so our doctors are they lead a team, and it's the same nurse all the time, it's the same medical assistant all the time on that team. It creates a continuity of care for the patient so that every time they come in, they know who they're talking to. Or if they call, they know who they were talking to, and they can say, so-and-so told me this. So that's what we've been able to develop. What it's done for us is it's reduced our cost per patient encounter by $75 per encounter. That's massive. The reason is because when patients are compliant, they take less time on the second, third visit. And that's the idea behind it. So as an administrator, you have to develop these programs. Nobody's there to teach you them. You have to find out what works and what doesn't. There's a lot of trial and error. Because depending on where you're going to be working will depend on your population. If you live in a population that has high income, they probably have, they respond really well. They want to be healthy, so they do what the doctor says. So socioeconomical situations have a lot of effect on a facility, whether it's the hospital, whether it's community health centers, or a public health center. All right, so what's the differences between hospital, public health, community health center, and private industry? Because there is a difference, and it's significant. Anybody know what an administrator does at the hospital? Most of the time?
Hiring, firing, making contracts with doctors, finances. I don't know.
Sometimes, but usually in a hospital, because they're larger, they have people to do all that.
Oh, okay, so
A lot of delegation.
Yeah, and so an administrator at a hospital deals mainly with their board of directors. And then they delegate everything and have certain positions. So a hospital administrator probably spends 75% of their time in meetings. That's all they do all day. They're in meetings every single day, all day long. And what they're doing is they're gathering information to be able to make decisions based on what they're told needs to be done, and then making sure how is it going to affect this department if I make this decision. That's a lot of what a hospital administrator does. And that's pretty much what they do all day. What about public health?
Making and writing policies, health policies?
Yeah, so they help out in that. And I think all administrators are responsible for most of the policy in an organization because it's what they live and die by. It's what they hold employees accountable for. Public health is sort of an interesting beast. All states have a health and welfare department on the state level. And then their sort of on-the-ground warriors are these public health departments. Now, not all of them provide the same type of services, but they go into areas and they find out where the most need is, and they try and provide those services. Most of it is done with very small budgets, so they're limited on what they can do. And so they have to decide, can we do this, this, and this, or can we only do this and this? And that's what public health does. So our public health departments around here have a very small and limited women's health program where you can go in for women's health checks. They have a really solid immunization program, and they do a lot of pediatric. Other than that, that's about all they do. And not all the public health offices can do that. A lot of them, because of budget cuts on the state level, will only be open 2 days a week to actually see patients. Otherwise, you'll be referred to the larger facility. So like at St. Anthony, we have a public health office, but there's only a nurse there twice a week, and she really can't do anything other than immunizations and maybe some, you can check for basic acute issues like a cold and cough, but if it's anything more serious than that, they have to send it to Rexford, because they just don't have the manpower to do it. What about community health centers? Kind of talk a little bit about that. Community health centers do everything. We work with our boards. We hire and fire the people. We oversee the daily operations. We are responsible for writing the grants. We oversee every aspect, everything that goes on in the health center. And then other than that, we spend the other half of our time working with state and federal entities to try and promote access to health care, finding ways to expand services, finding new avenues of money to come into the facility that helps sustain what you're doing. But the most important thing we do is we keep people out of hospitals. That's the number one thing that community health centers do. That's their number one result of everything that we do. What was the fourth one I mentioned? I know I mentioned another one. Private industry. I am a little biased. Although I think that everybody needs to be able to make a living, I question the motive sometime of the private industry. I'm going to give you an example. And I'm going to use me as the example. And it makes me wonder what some heads of companies are thinking when they make decisions like this. So I've had MS since 1999. Most people don't know it. I didn't start treating it until about 7 months ago, and I just found out that I can no longer treat it on the medication because I've developed antibodies against it. So I have no solution for MS. So they came out and they said, well, we have this one drug called Acthar, and you take it for 5 days, and you take it when you have a flare-up. And they says, okay, well, I guess I can do that. Well, your insurance isn't going to pay for it. Okay. Well, how much could 5 days... I mean, they're just 5 little injections. I got a picture of the vial. It's about that big. How much do you think it costs?
Vial, like for the whole 5 days?
Just the vial, which has 5 doses.
Oh, the vial has 5
The
doses?
vial has 5 doses, and it's that tall.
$1,000. $2,000.
Start out in tens. $28,000 for a vial.
At that point, would it be the pharmaceutical company who sets that price? Or
It's private industry,
Oh,
and it's what drives profits in private industry, whether it's pharmaceutical, whether it's an insurance company, whether it's a hospital, whether it's a local doctor. They're all being driven by money, and that is how they make their decisions. I'm biased because they limit access to care for people. They limit the ability for people, even with insurance, to gain access to health care. Because what is their number one motivation? Make money. That's it. So they base all their decisions on making money for the organization or corporation that they work for. That's private. That's what the private industry does. It's one reason I got out of pharmacy. The other reason is that my personality doesn't allow me to stand behind a counter. As you can see, I do a lot of this and a lot of this, and I'm not interested in standing behind a counter all day. I want to be actively involved in something, and I want to be moving forward. I want to be doing something all the time that changes and that evolves, and that I have the opportunity to navigate through and to be part of as it evolves. And so what I've done is that I've actually taken my job description of what, and I actually wrote this for my board. They said, write a contract for yourselves, and I did. This is the job description. There's 23 specific things on here. Pass those out. So you guys are going into health administration. I want to give you kind of an idea of what you're looking at. There's only 23 on here because I just got tired of putting stuff down. I mean, that realistically. So let's talk about a couple things on here. Obviously, number one, supports the operation and administration as the board advises. No matter who you work for in health administration, unless it's your own clinic, unless you own it, you're going to be working for a board of directors. Just the way it is. Which isn't a bad thing. Not always good, but it's not that bad. So you have to realize is that you have to have some really good people skills. You got to be able to communicate very well, and you've got to be not afraid to take some criticism every once in a while. Because boards have their own ideas collectively and individually about what you should be doing in their hospital or in their facility. And sometimes that's very, very difficult to manage. Our board is made up of 51% patients. So 51% of our board is actually made up of patients that go to the facility. And that's a federal mandate that we have. We can't change that. It's a good thing because we can learn from them.
So how many are on the board?
We can have up to 15 people. Right now we have 13. And so at least 7 of those actually are patients of our facility. And they come up with great ideas about how to increase quality because they experience it. So it's not always a bad thing. But sometimes it can be challenging. So you have to have really good communication people skills. Provides direction and advice to the board of directors in development and implementation. That's probably what I spend most of my time doing with the board, is educating them. They're volunteers on our board. None of them are paid. So they're not going to spend the time to understand the atmosphere of healthcare. It's my responsibility to educate them.